Madam Chair.
Yeah, we went to ask. Do you want us? Do you want us all to sit up there when we start?
I think so. It will make it a little bit faster.
Remind me your name.
Elizabeth.
It is a little from Uganda, yes? Yeah.
I'm looking forward to hearing what you have to say.
I should introduce you. My colleague Antoine has been working with MOH to do a paper on the like the grants to health facilities, because everyone is now talking about DFF. Everyone is talking about DFF, and Uganda was doing it before it was called DFF, but it's not written up anywhere, so no one talks about it.
Okay.
But anyway,
Thank you. So who else do you have?
Harry Delali.
Henry Delali. And Patrice.
Nitam Chagoma. You need their position.
Yes. Yeah, if you can get from me for Henry and then we see. Henry Delali is around. You can actually put his presentation on. Henry. We have Henry Delali. We have Newton Chakoma in the room. We have Tom Hart. Then Fahad is presenting instead of Lawrence.
Henry is going to use
Delali.
the presentation. Henry is that guy.
Yes, yes, yes. Via Zoom.
Yeah.
So how is it? So can we put it up?
Yeah.
You can already connect it. And here, I don't want us to start losing time when we begin. We can put it and then it just waits because it's the first.
Give it to us, but it's not explained well.
And to stop.
The sounds.
So if I say we start, can we start?
Yeah, we'll start. You think to share.
Okay.
Okay.
Hello.
Hi.
How are you?
Nice to see you.
too.
We're going to do a PFM.
Yes.
So Harry Delali, health economist.
Health economist.
School of Public and University of Ghana.
School of Public Health, Ghana.
Muzishyizeho.
School of Public Health, Ghana. And then Newton.
Is a PhD student.
Mhm.
The University of York.
Hello. How many additional chairs do you want? The guy two. Right now?
Yeah,
Man, yeah.
there's six
Yeah,
presenters.
this is
Plus me, which makes six.
7.
Okay.
3 more.
3 more. We do it now.
Yes.
Yeah, you're here.
The first presenter is.
The first presenter is Henry.
Okay.
Okay. I think that's. Well, I think they're just going to start.
Yeah, yes.
With the initial people will come.
Hello.
Hello.
Yes, unfortunately, we can't fit more speakers. We are able to fit in 5 people on the stage.
Okay. So at least give us the price.
I'm adding the 5th chair.
Okay. First come.
Yep.
Maybe.
Et voilà, présentation.
Mabuye agiye gushira. Nenge kubaza presentations muri ntuzanyuma zifite sibyo
hari n'izitarimo ariko
mubazi kuko n'ugiye oya ubwo bazi ko muri set rero.
Good morning, everyone. Would like to get started. The plenary session ended a bit late, and so people are coming in, but then we need to end by 11:30. And we don't want to continue being late, so we'll just start off. I'm sure by the time we begin the presentations, we shall have a few more people with us in the room. So I'm Elizabeth Ekirapa Kiracho. I'm an associate professor at Makerere University School of Public Health, and I'll be moderating this session. I'm looking forward to hearing what our presenters have to say and what we also have to share on this topic. So this is a topic on strengthening public financial management systems. When we talk about public financial management systems, we know that we are talking about the set of laws, count and audit public resources. And we know that public financial management systems have specific objectives that they're supposed to meet. They're supposed to promote fiscal discipline. They're supposed to promote allocative efficiency and operational efficiency, and also promote accountability and transparency. And strong public financial management systems that abide by these objectives are able to promote efficient and effective service delivery. But we know that what is planned is not always what happens in reality. And so we have several distinguished presenters with us this morning who will be sharing lessons from the work that they have been doing. So we have some of the presenters already in the room. So I'm going to invite you to just come and join me here on the stage so that we can start off. I'd like to invite Mr. Henry Delali, who is a health economist from the School of Public Health, University of Ghana. Please let's welcome him with a hand clap. Henry, you are welcome. We also have with us in the room, Mr. Newton Chagoma. Mr. Newton Chagoma is a PhD student at the Center for Health Economics and the University of York. So Mr. Newton, you're welcome. A hand clap for Newton, please. We have Mr. Tom Hart, who is a senior research fellow with ODI. You can just take the seat at the extreme end. Mr. Tom Hart, you're welcome. We have Mr. Fahad Mawanda, who is a senior health planner from my own country. The biggest clap for him because he is, yes, my countryman. So our presenters are here. We're going to start right away. I'd like to request that you take 8 minutes, but for the first presenter, I'll give you 10 minutes since I'm not too sure if the other presenters are around. And if they're not around, then I'll make it 10. If they're not around, then I'll make it 8, and we'll be very strict on time. Please do not let me embarrass you by asking you to close before you've really finished what you'd like to tell us. So our first presentation is going to be from Mr. Henry Delali, and he's done a qualitative study that is looking at the impact of context, decision space, organizational capacity, and stakeholder power on financing for primary health care. This was done in Greater Accra, Ghana, and it's based on a case study of one municipality. So Henry, you're welcome to share with us if you could take 10 minutes doing that.
All right. Okay, so good morning. My name is Henry. As you said, I'm a health economist from the School of Public Health, and I'm excited to share our research. We modified our topic a bit, making it a mixed method study on the effect of context, financial resource availability, stakeholder power, and decision space on financial resource disbursement for primary healthcare in urban Accra. So a little background. For Ghana, we have made significant strides in political decentralization, but our health system still operates some form of administrative decentralization, which means that the national level still has a lot of authority over the health system, regardless of the level. This dynamic usually plays out in a way that the local governments don't really have control over their portion of the health system. And research in this context is quite limited, but one study found that the decision space available for rural areas was low. Now, central government funds, which form most of their financial resources, was insufficient, was released erratically, and was basically not consistent. And their capacity to generate revenue, that is IGF, was low. No study had studied how these dynamics play out in urban areas in Accra, so we set to do that using one municipality as a case study. So this is our conceptual framework. In the middle, we have disbursement of financial resources for primary healthcare impacted by power and the uses of power, decision space, and then financial resource availability. Surrounding them is context within which these things play out. And we relied on Leitch's framework of conceptualization of context to explain it. Of particular relevance is situational and structural. Structural context is the economic and policy context within which the municipal operates, and situational context are transient events that impact resource disbursement for primary healthcare. For decision space, we relied on Bossett, who defined decision space as a degree of autonomy that local governments have over different functions, including financial control. And we have de jure decision space, which is on paper, in policy, what is the level of autonomy, and then in practice, what is the level of autonomy. We focused on the de facto decision space, which we used the financial resources received as against budgeted as a proxy for decision space, which helped us to classify them as narrow, moderate, and wide. For financial resource availability, we relied on the per capita revenue of the assembly. For power, we relied on Gaventer's power and classification of power, which shows in 3 dimensions. We have levels, spaces, and forms. Spaces are where decisions or participation takes place. Levels is our level is the power, whether national, global, local. And then for forms, we have visible power, which includes formal rules and structures that guide decision making. Hidden power, where that determines what is even what appears on the agenda. And invisible power is more subtle but powerful, as it shapes the beliefs and norms of what people think is normal. So we went on it's a single case study, as I said, with a rapid ethnographic approach employing mixed method studies. Our data collection period was from 1st June to 1st July 2024. For the quantitative arm, we did desk reviews. And for the qualitative arm, we did a combination of key informant interviews and observed their budget and planning process. And our period of study was from 2018 to 2023 for the desk review. So this is what we found for economic context. We said structural context influences disbursement for PHC in the municipal. We looked at their budget and we realized that health received a very low allocation of the budget. The total social services delivery department, which had health, education, and sanitation, received 30%, and health received just 21% from that sector. Then we looked at how much they spend on health. On average, the municipal spends about 2.3% of their revenue on health. You can see in comparison with other key sectors, we're doing relatively better, not so much, but relatively better. Now, the 2% translated to about just 30% of the budgeted funds that health hope to receive. And when the monies came, we saw a strong focus on capital expenditure, where about 81% of resources going to the health sector was mainly for capital expenditure. From our core findings, we uncovered that most of the participants were of the view that health was not a priority at the assembly. And for capital expenditure, it was explained that capital projects are visible and are quantifiable by the public. And so if any spending it should happen, it makes sense that it goes to capital expenditure. Then we looked at issues relating to their funding sources, all in to explain the economic context within which they live in. And we found that the main source of funding, which is the DACF is called the District Assembly Common Fund, which is about 5% of the national revenue spread across all MMDAs. Now, we realize that that particular source of fund, they receive less than 50% every year. And upon receipt, only about 9.5% goes to health. Now, we looked at IGF, which always exceeded their yearly budget, but even that we saw under prioritization of health because about just less than 1% was spent on health. For per capita revenue, they had about $9, which was higher than what was found in the rural areas, which was about $2. And what accounted for this per capita revenue of $9 was the IGF, because the rural sectors usually rely on DACF, and these guys had IGF that boosted their financial capacity. For policy context, there are guidelines that come with the funding sources that shapes how the money should be spent. For DACF, there is a compulsory 50% allocation for capital expenditure, and that could also explain why a lot of their funding went to capital expenditure. For IGF, they had about 20% IGF for capital expenditure as well. And then we looked at why is health not a priority? And what we found was that the conflicting decentralization policy around the municipal fostered an environment of mistrust where the health ministry is believed to have support from the mother ministry and does not disclose how much money they get. And so the assembly feels they cannot support until that is made clear. They can't give more funding to health or the health department because they feel they get more support from their health ministry. The health department also says, we can show you the books, but you will misinterpret. Yes. So the health ministry is also of the view that if this assembly sees our books, they will misinterpret the results and think we have a lot of money and will stop supporting us. So we uncovered that through our qualitative findings. Then we looked at power and how power was used. We said visible and invisible power used in closed and open spaces significantly influences resource allocation and disbursement. Why? The assembly has a structure for planning and budgeting. It has guidelines. But what we found was these participations were curtailed by late announcements of meetings, late notices, and late documentation, sharing of documents needed to be reviewed for insights. We also found that the MC, the municipal chief executive, holds political power over technical heads. In any resource-constrained environment, the leader can decide and override decisions of technical members, and this was what we found. We also found that advocacy and lobbying was key in determining resources that went to the primary healthcare. In the case of a hospital, an adolescent health clinic that was built, which only arose from the advocacy and the lobbying of the health director. Then we looked at decision space. Compared to rural areas, we found that decision space in the municipal, in urban areas was quite moderate. Not too bad, but not too good as well. And this decision space was boosted by the IGF, as I said earlier, because they had a lot of IGF compared to the rural areas. There's a market center in Medina, or in the municipal, we had this study, and so that had a lot of potential for IGF. Now, this decision space is further curtailed by the guidelines, like I said. So they get little money from government, and there's still an additional guideline on how to use it, and they don't have that autonomy to decide to use all the money for what they want. And then now this decision space is also curtailed by the limited and irregular receipt of the assembly's budgeted funds from government sources. This was also found in rural areas in Ghana in 2021 that found that limited and irregular receipts of the assembly's funds from central government reduced their decision space. So to conclude, we are basically saying that when you look at a municipal assembly in Accra, structural context influences decision space. There are economic policies, their economic context, their policy context all plays a role in shaping what decisions they make. We also said that power and the use of power shapes disbursement of resources for primary healthcare. Then we also said that decision space itself was key in determining what kind of financial disbursement they would make for primary healthcare. So we made the following recommendations. We said that looking at the fact that there's a national policy on a 50% allocation for capital expenditure, the national and municipal guidelines should be intentional about the provisions for both capital and infrastructure and programs. This would help balance the mix. Then we said that the relationship between the health department and the assembly should be improved through open dialogue, where you sit across each other and then we are honest with each other about how much we are actually getting from health ministry and how much you can help us with. Then we said that we realized that most of the key stakeholders in the process didn't have a good understanding of primary healthcare. So we recommend that the capacities of key stakeholders related to the municipal planning and budget process be improved so that they can lobby very well for primary healthcare, they can advocate for it, and ensure that primary healthcare is a priority at the municipal assembly. Thank you.
Thank you so much, Henry. I noticed that all of you are straining your necks by the time you come to present. We don't want to find when you are facing a lot of constraints. So I think I'll request you to just take your seats, except for Mr. Chagoma, who's going to present next. But for the rest, we'll call you up. If you're one of the presenters for this morning, please let our rapporteur know. So if you're one of the presenters, please just let the rapporteur know you're in the room. Apart from those who are at the front, we have 2 other individuals. So thank you so much, Henry, for sharing that and letting us know what is happening at that municipal council. Now we are going to be hearing from Mr. Chagoma. We know that a lot of our countries depend on development assistance for health. And this development assistance is not always on budget. Sometimes it's off budget, but we can be able to use our public financial management systems to align and utilize that development assistance more effectively. And so we are privileged to be hearing from Mr. Chagoma, who is going to be telling us exactly about that. You're welcome. You have 10 minutes.
Thank you, and thanks everyone. My name is Newton Chagoma. I'm a PhD student at the University of York Center for Health Economics in the United Kingdom. And I'll be taking you through this presentation on how does public financial management modify the effectiveness of development assistance for health. Next slide, please. Yep. Next slide. All right, so to begin with, if you may have attended the session on Monday, there was a good intro on what public financial management is. So you're looking at the rules and the protocol that govern the use of resources across public services, public sectors, including health as well. And again, we're looking at budget formulation, execution, as well as monitoring. And there is growing evidence that shows that public financial management systems hold the potential of improving health outcomes. And some of the authors here are like Maurice is here, he's done some wonderful studies on public financial management and its role in improving health outcomes. And I'm simply building on the work that these gentlemen and wonderful gentlemen and ladies have done. So when it comes to domestic resources, we know they're vital. Again, taking you back to the presentation we had on Monday, that countries that spend more using domestic resources, they stand way better on improving health outcomes. Again, but we know most low and middle income countries that have very tight fiscal space. That means DH comes to the rescue here, complementing domestic resources to make sure countries probably spend a little better on health than wouldn't have been the case without the development assistance for health. So approximately, if you look at the literature, about 35% and in some cases 70% of the health budget is funded externally. Again, I think there was Sarah on Monday, he made a good presentation showing how countries are faring in terms of the role of the split between domestic and DAH. So what am I then doing? What's the motivation of this study? So we know while DH is complementing domestic budgets, but there is limited evidence on how the use of public financial management systems could play a role in that. So we're looking at the PFM and DH dynamics and their impact on health outcomes. So the research question is, how does the effectiveness of DH change when it is channeled through weak versus strong PFM systems? And the objectives are there. We're trying to look at the impact of PFM on health outcomes, pretty much building on the works of Maurice and others, but just in a different way. And again, we're investigating the impact of the PFM and DH dynamics, and also looking at how the Paris declarations on aid effectiveness have improved or probably not improved health outcomes, or have translated to public health gains within the health sector. Next slide, please. So basically, we're waiting for the stride to free. We're looking at the pathway that can maximize the use of development assistance for health. And in terms of methods, I'm using here a dynamic final model, a generalized method of moments. The whole idea is, let's try to establish some sort of causality in terms of the relationship between PFM and health outcomes. Also, if there's any sort of causality between PFM and DH interaction with health outcomes. So we have infant mortality and under 5 mortality as outcome variable, and also we're controlling for one of the key variables here is a GDP, per capita GDP as a controlling the size of the economy, and also we're controlling for public health expenditures. And that's simply the equation. So we're using a generalized method of moments here, using those two systems of equations with the idea of trying to use some instruments, internal instrument within the model structure to make sure probably we move towards establishing a causal link between PFM and DH dynamics as well as health outcomes. Next slide. So in terms of the data sources, we're getting the data on PIFA from the PIFA Secretariat, and also the World Bank. They have data on the Country and Policy Institution Assessment. And also there is the WHO JED, as well as Organization for the Economic Cooperation, the OECD. They do have some data on DAH as well. And the quality of PFM systems is measured by the PIFA, as well as the CPIA. And there are some complementarities between these two quality measures. However, I would like to draw attention to the CPIA score, which specifically relates to the quality of budget and financial management. That's the one that I feel like is more closer aligned to PFM than the broader CPIA scores. And if you had attended the session on Monday as well, there was a good explanatory on sort of the pillars of PIFA and how those relate to improved health outcomes. So in terms of our outcomes, we're looking at infant mortality and under 5 mortality, and that's the scope of variables to my left in terms of what sort of variables are fed into the model. Next slide. So what are we finding? What have we come up so far in terms of the impact of DAH on health outcomes? So I used 2 models, the fixed effect, the standard fixed effect, as well as the generalized method of moments. And I must mention here that the GMM is a primary specification. So whatever happens, the difference is the GMM, that this is our primary model that we're referring to. And looking at the model here, we see that PFM has some value in terms of improving health outcomes. Sorry. This is a slide on the impact of DAH on health outcomes. The whole idea let's start with the basics. The literature says some gains in public health because of DAH, others say no. But what I thought is, let me start with my data here. Like, what should be the starting point? So the starting point should be, does DAH improve health outcomes? Yes, we're proving that here, confirming what is already available in the literature. It's small, but we see it's a small proportion, but still it's something. And we see that across all that as well, we see public expenditures, which are domestic public expenditure. They do have a role as well in improving health outcomes, confirming what again is already established in literature. The second slide. In the next slide here, we're looking at the impact of PFM quality on health outcomes. So using the generalized method of moments again, as well as the standard fixed effects model. Here we see, based on the fixed effect model, that indeed PFM has some impacts on health outcomes, about 0.17 or 1.8%. And the same thing, we see that when we're moving towards the GML model, the magnitude of effect gets even a bit larger than in the other model, confirming again the consistent trend that, well, what others have found in literature using different methods, we're able to draw consistency in terms of our findings here, like, well, whether using OLS, using these probably GMM, the conclusion remains the same. PFM has a law, it does improve health outcomes. Next slide. And also here, I'm using the PIFA score. So we've used the GMM in the other front using CPI scores. And in this aspect now, I'm using the food OLS. Again, trying to confirm the same story. So what happens if we use the PIFA scores? We see the same story. Indeed, confirming what is already available in the literature, using a different probably analysis, we see that indeed PFM has a role in terms of improving health outcomes. The next slide. So here now, that's where we begin the core question that we're trying to address, like, how does the interplay of PFM and DAH improve health outcomes? So I begin here with the general overview to say, what if we take DAH in absolute terms and look at the impact in terms of health outcomes? So we see here that there is a marginal effect of PFM-DAH interaction on improving health outcomes. Now, because this is an interaction variable, we can't interpret it directly, so we have to use some marginal effects to see like what happens when the levels of PFM quality improves onto the impact of DAH on health outcomes. So I do not show the graph on marginal effects, just to make sure I balance on the slide, but indeed we see as the quality of PFM improves, we see some improvements as well in how countries are utilizing development assistance for health. So some gains there. But however, when we shift to in the other one for child mortality, fixed effect model, we see the signs are consistent, showing a decrease in infant mortality, but they're not statistically significant. So probably I'm noting in late there, like the challenges could be the challenges in estimating DAH, because when you look at the WHO metadata, they make a statement that when their contribution benefits multiple sectors, they only record the sector which received the highest share. So which means probably there is a potential of underestimating what should be the true or the actual amount of DAH that should be categorized as on budget DAH. Or probably it could be an issue of utilization, budget execution, or absorptive capacity across government, across countries. But on budget is there, but probably countries are not able to use the funds as required within the stated timelines. So that could be a factor probably. Or simply it could be an issue of aid fungibility where when governments know that we will have a little bit of money here from our colleagues, from our donors, instead of directing it to most programs that will have direct impact on health outcomes, they do it to probably less distal programs. So that could be an issue as well. I still have some minutes here. So lastly, I'm looking at the impact of the Paris Declaration on aid effectiveness. And what I'm saying is probably they seem to have some positive gains in terms of improving health outcomes. And how do I approach that? So I'm looking at the whole period between 2005 and 2021, 2022, a period when we have PFM scores from the CPIA, and also just looking at, well, probably these the declarations were declared around 2005, but then you have like the 4 Accra Agenda for Action coming around 2008, 2009. So I assume that probably 2009 could be a good cutoff point given the policy implementation when it comes to programs. So in the overall analysis, we see that both between the 2005 and 2021. DAH per capita had some positive gains in terms of improving health outcomes by about 0.6%. And when we split the sample, just focusing on the post-Paris era, what we see is that the magnitude gets even a bit larger, probably suggesting that there are probably more gains from the implementation of these declarations. They may not be perfect, but we see some gains. And again, in the post-Paris era, we see no, pre-Paris era rather, we see no effect. One could argue maybe because the sample size could be a bit small, and that could have implication in terms of what we're seeing as the results here. But what we're seeing is probably in the post-Paris era, countries have tended to utilize beta as a result of the 8 principles of harmonization, alignment, as well as the joint management of results and accountability. So what I'm concluding is these findings suggest positive impact of the Paris Declaration on aid effectiveness, extending its benefits towards the health sector. The next slide. So in terms of summary of findings, so we are reaffirming the beneficial impact of DAH. Of course, DAH has been cut, drastic uncertainties are there, but still must score some positive gains in terms of improving health outcomes. And probably what I'm doing here is searching for pathways that can help us utilize the few resources we're getting from donors, and we spend them better. So the post-Paris Accra period appears to be one where countries have sort of optimized the use of DAH, but still more work to be done. And the beneficial effects of PFM systems are apparent, as we've seen across both models, looking at the using PFA, using CPIAs, we're getting a consistent story that PFM systems matter. They have a role to play if we are to improve health outcomes. And again, one of the things probably that comes out from a discussion that I've attended so far is adjusting or customizing the PFM systems to making sure they are tailored for the purpose, given what our countries are experiencing. And while we do not find the quantifiable effect of PFM and DH dynamics, I think there are still positive effects to be drawn given what we're seeing in terms of, if you're looking at it from a theoretical perspective. Probably if donors would direct more resources or partners put more resources on budget means it could reduce fragmentation, it could reduce duplication. All these things, if you look at the aid literature, they have so much negative effects in terms of improving the effects of development assistance for health. And in terms of policy implications, reassessing the balance between on budget and off DH, probably one way of trying to see like, well, things are not working as supposed to be, but probably maybe if you push resources more towards on budget support, you're moving away from duplication, fragmentation, and these things can improve health programming, resource utilization, as well as helping planners to plan better, given that they'll have like a wider view of resources rather than tunnel vision kind of planning. And also prioritizing on budget support, I think I already said to that one, and integrating DAH into the country sector strategy probably could be a better way of, again, giving donors a responsible transition. Like, well, we will not find you for eternity, but at least when you have, well, if you communicate effectively that, well, by this period to be transitioning out, I think it gives donors also a good time, a responsible transition manner, as well as countries to prepare to say, well, I think this is what's coming up, probably let's rethink on how we should strategize. And lastly, I think when it comes to challenges in estimating the effects of on budget DAH, probably for analysts here and practitioners, there is a role for us to play in terms of how developing new methods of estimating on budget DAH. Thank you.
So thank you so much. At the end, we shall have some time for questions, but we'll also have time for you to share your insights, because at the end of the session, we don't just want to ask questions. You've come with a wealth of knowledge, a wealth of experience. We'll give you an opportunity to also share that. I just want to find out if the other two presenters have joined us. Mark Akanko, if you're in the room, just slip your hand up. And Naomi Ndao, if you're in the room, your hand up. If you know these presenters, if they come, please do tell them to let our rapporteur know that they are with us. We'll now move on to our next presentation, and I'll take you all the way to Uganda. PFM systems sometimes have some weakness, need to be strengthened. So we are going to be hearing from Mr. Fahad Mawanda. He's a senior health planner with the Ministry of Health in Uganda, and they have been doing some strengthening of the PFM system, and he has experiences from 2 districts. Mr. Fahad, you're welcome.
Thank you very much. We have, as we wait for the presentation to load, Ministry of Health, Uganda, collaborated with CHAI, Clinton Health Access Initiative, with support from CIDA to undertake some interventions in some districts with the hope of learning to improve and roll out the lessons to the rest of the districts. So Uganda, of course, implements the decentralization policy, and funds are sent to the district local governments as well as health facilities. And we are specifically talking about PHC and the non-wage component. However, many districts struggle with low budget absorption, poor accountability, and other PFM issues. So we undertook a bottleneck analysis to try and identify some of the critical issues. And the findings were that we identified low budget absorption at the district level, non-prioritized utilization of funds, as well as limited visibility of funding flows. So we undertook, of course, the assessment was done on 6 districts, and we chose 2 districts that were poorly performing. The names may sound strange. One of them is Kasanda, and the other one is Kakumiro. So those are the 2 districts that we focused on. And we undertook to build the capacity of staff, both at the district level as well as the local, the lower level facility, health facility in charges. And then we developed a district budget execution tool with a dashboard to try and track as they implement. The goal was to improve planning, budgeting, and tracking at the subnational level for efficient utilization and accountability of funds for delivery of essential health services. Next slide. Yes, so we trained 90 from the 2 districts, 90 participants, and 40 were from the district level, and then 50 were from the lower level facilities. We identified some resource persons who would facilitate on the basic PFM concepts for these health facilities. And we also developed, the aim was to empower these health workers to develop evidence-based, service delivery focused and integrated annual work plans using a template that was already designed by the Ministry of Health. And then the participants were also taken through how that Excel-based template, the dashboard works, so that they could easily track their budgets. Next slide. So in terms of undertaking the challenge, we identified the key 3 challenges: the low budget absorption, the non-prioritized fund utilization, as well as limited visibility of the funding flows. So the interventions were mainly training these health workers in developing a comprehensive annual work plans, because one of the issues we identified was that a partner comes and they have maybe an HIV work plan, you have a malaria work plan, something like that. So we wanted to have a comprehensive work plan so that the plan is all in one place so that we avoid duplication and other issues. The other intervention, like I said, was developing a district budget execution tool, which would really help them to know what they prioritized, how much money came, and how much money was spent on what activities. So that was very easy would make it very easy to track. And then lastly, we introduced the concept of having PFM mentors at the district, basically from the district health teams, to constantly keep mentoring the lower level facilities who have issues with the PFM concepts. Because this now also comes with the challenge of staff attrition, then the transfers, where facilities get new staff who you had undertook a training, and then the new staff come, the new staffs come and they don't have the concept. So the district mentor based at the district would help to keep on mentoring these issues, these health workers. So in terms of the expected outcomes, we expect this would improve the budget absorption, service delivery, focused fund utilization, and then improved accountability. Just to mention that this work is still ongoing. It is a project of 4 years, starting in 2023 and ending in 2026. So these are some of the results that we expect at the end. Next slide. So this is how the dashboard looks like. Just we look at the budget release performance. Money doesn't come in terms of the activities or the outputs, depending on how the district or facilities categorizes in the work plan. But when money is released, they can proportionately allocate the money to know so much has come for this activity, but they can do a reallocation depending on the prevailing priorities at that time. So, but it helps to know how much money has come in relation to what was budgeted for, and then they can also spend and know how much has been spent on what activities, so that they can easily track whether they are implementing the activities in the work plan or they have just diverted and chosen to implement activities that are not aligning to the work plan. Next slide. Yeah, so in Q1 of the financial year 24-25, which started in July 2024, we collected some data and we observed that 68% and 76% of the funds that were dispersed to the districts, the district health departments, were absorbed. So the absorption was at those percentages. The health facility findings are not displayed here, but we note that 75% of the planned activities at health facility level were successfully completed. But now when we look at, if you look at the guidelines, which will specify how maybe they give you 30% must be invested in a certain category of activities, that is where we had challenges with some facilities, whereby 17 out of the total health facilities in the 2 districts fell below the threshold of the 30%, according to the guidelines, which had to be invested on health promotion, disease prevention, sanitation, and hygiene activities. So the absorption is there, as you can see, but they are investing the money on some activities that are not aligned to the work plan as per the guidelines. Next slide. So we look at the possible reasons for your utilization. Capacity losses through attrition of trained facility in charges, which I had hinted on earlier. So there's a lot of transfers, there's some in charges go, and then the new in charge that comes doesn't have enough capacity. Then we had issues to do with the funds reallocated due to emerging issues such as Ebola and monkeypox outbreaks. So these ones now they deviate from what the work plans had initially indicated to be implemented. But our message is that if this happens, then we have to get the quick and necessary approvals as per the guidelines. So in terms of the differences between high and low performing facilities, we sought to explore facilities that were complying with the condition of the 30% investment in a certain category of activities at the higher level. So we wanted to know whether the higher level facilities are the ones complying and the lower level facilities are not complying. But our finding was that that is not the case. The issues were across all the facilities, irrespective of the levels. Then for the struggling facilities, wanted to know what are the specific reasons for low performance. Do they have some unique issues? Have the issues been reported to the district? Do they need any support? We realized those are still the cause of the low performance is, as per the earlier alluded to, issues to do with capacity issues. So we think the key interventions for improvement, we emphasize strengthening planning and oversight, ensuring that work plans align with fund utilization targets. Accountability mechanisms, use of the real-time, the dashboard that we talked about for decision making in districts. And this is done on a quarterly performance meetings. So when you do the tracking on a quarterly basis, then you have to discuss the findings in a quarterly performance review meeting. So the quarterly performance review meetings we emphasize should be done at the facility level as well as the district level for timely interventions instead of waiting for the whole year to elapse and then when you have issues. So want to leverage the support, targeted support to low-performing facilities to improve implementation of PFM interventions for health service delivery. Next slide. Yeah, so some of these have already been talked about, targeted and continued support to the health facilities that are lagging through the help of the identified district mentors who are resident at the district instead of waiting for someone from Ministry of Health. Then integration of PFM mentorships with routine support supervision visits by the district health department. So as they do their routine support supervision, the PFM aspects have to be put in place. Then facilitation of the district mentors with digital devices to ensure timely submission of health facility mentorship data. And lastly, documentation and dissemination of training process through resource guides and manuals for reference in the selected districts. Next slide. So this is the last slide. We are saying by strengthening public financial management at the district level, Uganda can reduce wastage and inefficiencies in fund utilization and hence enhance essential health services for many people. This approach provides a scalable model for other districts across the country. Thank you very much.
Mr. Fahad, for those practical examples. One time I was in a district in Uganda, and the district health officer was with some of his team members. And so he said, we've received some money for development. What do you think we should spend it on? And then someone said, let's expand the postnatal ward. Then another one said, we need to construct, the pediatric ward. And they started proposing things. And I was thinking to myself, is this how they're going to decide to utilize these development funds? So when he talks about, prioritization and how these funds are actually put to use, at times on the ground, you find all sorts of things happening. So these kinds of health system strengthening activities that focus on how the finances are allocated are particularly important. Before we move to our last presentation, I'll once again make a call. Now I'm on the second call for Miss Naomi Ndao, if you're here, and Mr. Mark Akanku. The next call will be the last. So if you're here, please do show up. So in the next presentation, we are going to be focusing on Ministry of Finance. All of us in health are always asking people from Ministry of Finance for more money. And often they do not have the money to give us, and they have their reasons. So our last presenter, Mr. Tom Hart, I'd like to welcome you. He's going to tell us about how can we make our discussions with the Ministry of Finance more fruitful. What can they offer us if they cannot offer us the money that we are asking for? So Mr. Tom Hart, we are all ears to listen to you. You're welcome. Mr. Tom Hart works with ODI Global. Welcome.
I want to acknowledge my colleague Danielle Cerebro, who this work is co-authored with, and we should be publishing the paper that this is based on in the near future. Next slide, please. So as Elizabeth outlined, the kind of rationale for starting on this paper is often the first kind of request from Ministries of Health to Ministries of Finance is that there needs to be more funding, more investment in health. And there is a clear rationale for that because of low investment levels, but we know that many countries, especially in Africa, are facing a financing squeeze. The IMF has called this recent period the big financing squeeze, as debt levels, the cost of servicing debt increases, as other pressures from recovering from COVID, like education recovery and getting infrastructure funds back on track, take place as well. And when we look historically back at the share of government expenditure that has been devoted to health, it has tended to be quite sticky, we haven't seen large shifts, and broader analysis has found that where there is increasing in health spending, it's generally come from general increases in the proportion of GDP that is spent on expenditure through increased taxation, or from just general growth in the economy, rather than from large reallocations in the budget towards health. So if a Ministry of Finance can't or won't increase the budgetary allocation for health, what can it do? And that's the real question we wanted to answer. And I think there has been kind of fairly long-standing calls for better engagement on health spending between the Ministry of Health and the Ministry of Finance, specifically thinking about what the specific needs of the health sector is. Next slide, please. So to kind of organize our thinking about this, we started off with the kind of standard budget cycle, which you can see here, and particularly it's the processes where the Ministry of Finance and Ministry of Health interact, which is largely on the budget formulation process, and then during budget execution. This is less on budget approval, where the interaction is with the legislature, and less on the budget evaluation, although somewhat where a lot of the processes with like the Auditor General and other oversight agencies. So we went through this and looked to try to think it through, organize the kind of academic and grey literature on how the Ministry of Finance and Ministry of Health interact and how that can be improved. And we also thought about considering the kind of different roles that they play in the PFM in the PFM process, kind of slightly outside this. So what we kind of aim to do is thinking about how ministers of finance can help improve the quality of health spending. This is not kind of providing concrete prescriptions. This is, if you like, a menu of options that some countries may choose to take up, but it's an aid to thinking rather than a clear set of specific recommendations. Next slide, please. So starting off on how ministries of finance can help improvement health sector planning and budgeting. The first step on effective planning is widely acknowledged to be that you start with a resource-constrained planning process. But we have evidence from studies of health benefit packages and so on that actually this is the most common failing of existing plans and benefit packages in low-income countries, that they are not adequately resource-constrained. And if a plan or health benefits package is not resource-constrained, it can't be used as a basis for prioritization. And so that will need ministries of finance to engage more meaningfully with those processes, and specifically to help provide ministries of health with the guidance as to the likely resources available on a kind of medium-term basis. A second area is balancing top-down budgeting with bottom-up inputs. So all of you who have looked at budgeting processes or been... Can you hear me at the back okay? Yes, perfect, okay. Those of you who have been involved in a budgeting process will know that typically a budgeting process will start off with a Ministry of Finance setting sector ceilings for different agencies. And, you know, that is an important part of the process to make sure that the budgeting process can achieve the kind of aggregate fiscal discipline that is needed. But there also needs to be a balancing of that with allowing the Ministry of Health and the health sector more broadly to propose new areas of spending as well. So it's important that the Ministry of Health is given flexibility within that sector to prioritize and allocate as it sees fits, and also to make proposals for new areas of spending should there be fiscal space available for that. Although inevitably the Ministry of Health would be competing against all the other government agencies for any spare fiscal space. And I think a key part of that process working well is building trust between the Ministry of Finance and the Ministry of Health, and specifically between that planning and budget department or finance department in the Ministry of Health. And lastly, you know, the Ministry of Finance should provide an effective challenge function to the Ministry of Health. So by this we mean the investigation and scrutiny of the policy choices of line ministries. So when a Ministry of Health is presenting a budget, it should be expected to be scrutinized and reviewed by the Ministry of Finance on the quality of those budgets. Next slide, please. Lastly, budget processes are time constrained. They have to meet parliamentary deadlines. They are inevitably end up focusing on the kind of small incremental increases or decreases in the budget. But this can mean that the kind of broader set of spending that the Ministry of Health supervises is not effectively scrutinized. In OECD countries, over the last decade, we've seen a large increase in the use of spending reviews to scrutinize public spending more broadly. And we think this is something that should be more widely considered by finance ministries as a way of collaboratively examining the quality of public spending in the health sector. So now I move on from the kind of planning and budget process of the budget cycle to the budget execution process. And for those of you who were here on Monday, you heard that kind of low budget execution is a common problem across Africa, and we think, you know, this can be improved by ministers of finance supporting ministers of health with strengthened cash management and through kind of less rigid and more flexible spending controls, so that line item rigidities are not causing underspending just because, you know, budgets are forecasts of future needs, which may not always be accurate and need to be adjusted in year. A second area on budget execution, we know that salaries are obviously usually executed fairly reliably. So it's the supplies and commodities that are tend to be less well executed. And there's also scope for improving the efficiency of that spending as well. And their Ministry of Finance can work with the Ministry of Health to make sure that the government-wide standard procurement arrangements may not have been designed with the specific needs of procuring health commodities in mind. So the Ministry of Finance and Ministry of Health can review whether the procurement procedures of government are fit for purpose for the health sector. Next slide, please. And the last area that we've looked at, so from planning and budgeting through budget execution, is looking at the roles in the different the Ministry of Finance and Ministry of Health play and how they interact with the broader public sector systems. So the first one of these is how the PFM cycle and the PFM system interacts with the fiscal or the decentralization system. So we know that most African countries are delivering healthcare through decentralized systems. We've heard from the presentations just in this session through districts in Ghana and Uganda about some of the challenges that the local governments are facing in delivering healthcare. So because the Ministry of Finance usually plays a major role in setting the kind of fiscal aspects of decentralization, such as regulating the intergovernmental fiscal transfer system that transfers grants to local governments for providing services, and also regulating and supporting public financial management systems are set up, that is a clear area where ministers of health and ministers of finance need to engage to make sure those systems are set up to promote effective service delivery. A second area where I know there are several sessions in the conference on this is making sure that the PFM system allows for direct financing of facility operating budgets and some financial autonomy, as I think we have a growing body of evidence that is supportive of increasing the utilization of healthcare. We also think there is potential to leverage new digital technologies for better fund flows to the front line, making use of digital reforms to make it easier for frontline facilities to budget and account for the funds they receive, and for better integrating the financial and non-financial performance data for efficiency analysis and so on. The last area is thinking about revenues and thinking about the role that health taxes play in efficient or in improving the health of the population. We know that the World Health Organization sees excise taxes on alcohol and cigarettes and on sugary drinks as some of the most cost-effective best buys to tackle non-communicable diseases. So there can be revenue can be raised and health spending pressures can be reduced by implementing these taxes. And obviously design of those taxes will be the primary responsibility of the fiscal authorities, whether that's the Ministry of Finance or a Revenue Authority. And the Ministry of Health will need to negotiate jointly about the design of those taxes, such as the base, the rates, and so on in there. Next slide, please. So then this is just to summarize, these are kind of the sort of 10 areas we've covered where we think that beyond just the amount of money that is going to the health sector, where ministries of finance and ministries of health can collaboratively engage to improve the quality of spending and improve the effectiveness of health spending in a country. So I leave it there for you. Thank you.
Thank you so much. And I'd like to thank all the presenters for keeping time. And I'll make the last call. Mr. Mark Akanko, are you here? Or Miss Naomi Ndao? Okay, I assume you're not there. So I'd like to thank our presenters for those very insightful presentations. And I'd like to invite them back here so that we can be able to have some exchange. As I mentioned earlier, you've all come with experiences from your country. So would like you to share some of the experiences. Would also like you to ask any questions where you'd like clarification. Our presenters, please do come back to the front, come and join me. Yes. So we had from the first presentation, Henry presented and told us about how there was a leaning towards capital expenditure with inadequate money for some of the other program needs. He also noted issues to do with limited decision space, issues to do with capacity. And when Mr. Fahad presented his work, also indicated some of the capacity weaknesses that were there, but also challenges such as low absorption and failure to allocate money according to some of the activities that were supposed to be implemented. And we heard from Mr. Chagoma about the use of development assistance for health and how that can be beneficial, and also how the PFM system can also, when the systems are strong, they contribute to reducing mortality. And there were issues with estimating DAH assistance that is on budget. And in the last presentation, Mr. Tom had emphasized some of the actions that we need to take to ensure that the public financial management system is more effective, and what we can be able to do together with the Ministry of Finance, translating the plans into budgets and work plans and ensuring we are prioritizing the key activities. So we still have a few minutes left and would also like to hear from you. So you can put your hand up if you have a question, or if you have something you'd like to share. We are not restricting ourselves just to questions. We would also like to learn from one another. Yes, I can see a hand up there. Please do go ahead. Make your contribution precise and specific so that we can take as many contributions as possible. Okay.
Thank you to all the presenters. My name's Alex Winch. I'm with the Global Fund, and it was more a comment responding, I think, also to the presentation by Tom, and more for the broader audience, because we approached ODI and Tom from the Global Fund with a simple question, and that was really, how can Global Fund, but more broadly, development partners be better partners to ministries of finance? And that's, for us as Global Fund, a multilateral fund to fight AIDS, TB, and malaria, our primary interlocutor has always been ministries of health. But if we're talking about sustainability transition, we realize that we need to more effectively engage not only with ministries of health, but ministries of finance as well, to have that serious discussion. So Tom said, well, look, as a first step, let's get that discussion between ministries of finance and ministries of health going. Let's propose some options. And then as a second step, Global Fund can kind of take those recommendations, some of the points that he's outlined, and create their own position on supporting governments to have that discussion. So I would be particularly interested with any ministries of health here or ministries of finance for their inputs, because as Tom mentioned, we're going to have a launch of this broader public good, this paper later in the year. And so your inputs to finalize that would be greatly appreciated. Thank you.
Okay, thank you. There's another hand at the other table. If there are other hands, please do slip them up.
Thank you very much. Thanks to all the presenters. My name is David William from the Minister of Health in South Sudan. My question is going direct to
If you could
Henry.
speak a little bit more loudly.
Maybe it's from the mic. My question goes directly to colleague from Ghana, Henry, or maybe also Tom may also give highlight on that. The issue to do with decentralization conflict that has come very clearly on their presentation between the level of the government. We understand that most of the region actually using the decentralization system whereby the primary healthcare funding flows from the national level to the district level. And of course, this has been a major challenge that we are facing currently. Funds have been flowing, but input from the district level or the state level are not showing clearly, because suppose state level should have their own budget. What comes from the national level has to be an complementary, whereby they also need to put something because they're generating revenue. So this has not been coming very clear in our side. So maybe they can shed a light on that with their experience as they have been facing challenges toward that. Thank you very much.
Okay, thank you. Any other questions? Please do slip your hand up. Okay, so yes, let's take two more and then we shall respond. Okay, three, I can see three hands. So we'll take those three and then we shall respond. Please do, go ahead.
Thank you for the presentation. My name is Antoine, I work for ODI. I had a question for Lawrence from Chai on the Uganda presentation. I was wondering if the analysis covered the vertical programs implemented at the local level, because I saw that some of the activities listed, like HIV or immunizations, are often covered by the vertical programs as opposed to the PHC non-wage recurrent grant, which is often very limited in size. Because I saw some of the challenges were the limited predictability of funds over time, and then the absorption issues, which is often like an issue with vertical program funds, because the non-wage recurrent grants in Uganda is quite stable over time and predictable, and it's executed pretty highly. So I was wondering if there was a distinction between the two, or was it only covered the PHC grant? Thank you.
Okay, thank you. There's another hand here, and then one at the back, and then a last one.
Thank you so much. I'm Walimbo Ali from Minister of Health Uganda. Just making a comment that I think the strength in having PFM intervention successful should begin from planning. We realize that when colleagues were talking about budgeting, it was separated from where you come from. So you cannot perform very well when you have not gone through the budgeting process. So in Uganda, that's what we're doing. And I think the last presenter, our colleague mentioned that without getting planning very well, the rest of the things are bound to be either guesswork, and including expenditure, you either spend more or less because you did the guesswork. I think the facilitator here demonstrated that people get money and they start thinking of what to do. And yet you need to have thought through the process so you can be efficient, but also do proper prioritization. I think this is what we need to think about as we front PFM intervention. Thank you.
Okay, thank you. So we'll have two last hands. I think there's a hand at the back. Is it still there? Just two. I'm sorry, we can't take any more. Our time is almost up. So there's a hand right at the back, and then this one.
Okay. All right. Thank you very much. My question is for the gentleman from Uganda. He talked about mentors providing some sort of support for PFM at the PHCs. Now I'm wondering if the mentors are government employees or people taken from the community, and what sort of sustainability mechanism is in place to ensure that the mentoring goes on, and how is the mentoring also, how is the performance of the mentoring monitored? Thank you.
Thank you. Then the very last one, right at the back.
Thank you. My name is Peter Binyaruka. I'm a health economist working with Ifakara Health Institute in Dar es Salaam, Tanzania. I have a quick question for the presentation about the DAH with PFM. It's quite interesting analysis, the way you have done. But I was quite curious to see whether you have tried to look on the intermediate outcomes, to what extent that could be affected. Because just looking on the health outcome at the end in terms of infant mortality rate, those one could be affected with other factors beyond financing. But at least the intermediate outcome, including, let's say, utilization, at least you could see something which could maybe part of the pathway towards improving health outcome through PFM and the DAH. Thank you.
Okay, thank you. So I'll just request each of the presenters to respond to whatever question was directed to them. We can start from over here. If there was no direct question, you can still give a comment.
Okay, thank you very much. I want to respond to the issue, the concern regarding the mentors that we talked about. Now, the mentors are staff of the district local government, are part of the district health team. We think this will now, for sustainability purposes, but these are staff who attended the other training, and for those who were indicating some serious interest and getting the issues very clearly, we again retrained them. So the way the mentorship happens is every quarter they go to the facilities and collect some basic data. There is a small tool, a simpler tool, to check if the facilities are actually following the PFM concepts that they got, whether they are implementing as per work plans, whether the revisions are being approved or everything like that. Now, when they capture the issues, if there is any concern that needs the attention of the concerned people, they bring the concerns to the people who are concerned. If it is something to do with audit, maybe they have identified the facility doesn't know how to audit, to account well, then they bring it to the attention of the concerned officers at the district for immediate intervention. Yes. So there was also a concern, I don't know, I'm not sure if I captured the issue very well, the activities that are indicated there. We are advocating for a comprehensive work plan that has everything. Now, for activities that are getting direct financing, maybe from the ministry, that is not going through their district budgets, those ones have to be indicated. They will indicate that we did this activity, but the funding for this activity did not come from our budget. We got special money that was released for this activity. It happens in the reporting, so it is well documented. If the money came through their budget, then they will also indicate it very clearly. I don't know if I got the question very well. Thank you.
Also one on whether vertical programs were included.
In the work plans?
Yeah.
The vertical programs, they are supposed to be included in terms of enumerating the activities that are going to be done. So the work plan has all the activities that are supposed to be implemented, and then when you come to the budget, it specifies this one, the budget is for which activity. But the work plan is expected to have all the activities enumerated. Thank you.
Thanks. I mean, maybe first to thank Alex for his comment and just emphasize that if you found what I presented interesting, if you'd like to discuss further, please do reach out. Just on the question from the gentleman from South Sudan on whether subnational governments should be allocating some of their own resources to the health sector. I think this really depends on how subnational governments are financed. Most subnational governments will tend to be quite grant dependent. but the structure of those grants can vary a lot between countries. So if we looked at like Uganda or Tanzania, we find that the districts are mostly financed by conditional grants. So they have some grants earmarked to the health sector already, and the kind of unconditional finance they have is actually relatively small. So it's quite hard for them to allocate additional funding to the health sector beyond the conditional grants that are there. If we look at countries like Kenya or South Africa, the subnational governments responsible for healthcare are generally financed by a single large unconditional fund. There may be some smaller conditional grants as well. So in those cases, it really is the role of the subnational government to decide how much it's going to allocate to health as well. That would be also the same for states in Nigeria, for example, as well. So how much the subnational government needs to decide to allocate to health versus how much that is effectively already dictated by the structure and the makeup of the conditional grants will vary from country to country.
Hello. So I think there was a question from Tanzania on whether I had a thought of including intermediate outcomes. I think I didn't really think about intermediate outcomes because my understanding was, I think when it comes to population health outcomes, infant mortality and usually infant mortality and child mortality are usually utilized as markers for population health outcomes, and that was the thought that I had. But I think it's an area worth exploring, just trying to see like what happens if we introduce, say, probably immunization or NC utilization, like what happens in terms of the outcomes, or whether probably might see a different perspective in terms of the outcomes. But yeah, thanks so much for the contribution.
Yeah. I don't know if I got the question right, but it was on how to resolve the issue of the decentralization conflict, right? So right now in Ghana, our Local Governance Act is on its own, and then the Health Services Act is on its own as well. So one way to be able to solve that problem is to harmonize them, where we align the mandates of the Local Government Act and then the Health Services Act, so that the roles, the responsibilities, and then the funding mechanisms are clear, right? Another way we can, in addition to that, the health departments, they receive funding from their health ministry, and the lack of transparency on their path is what is making support from the local government limited. So they have to sit together and plan and budget, so that when you look at the health budgets, they will tell you these activities we are expecting our mother ministry to fund us. These activities we are expecting you to fund us. Then they can know exactly what kind of support they can give to the health department. I don't know if I've been able to. Yeah.
Okay, thank you. So unfortunately, we've run out of time, so we shall not be able to take more questions. But I hope that you've been able to get some insights from this session. I want to particularly thank our presenters. This has been very insightful, and thank you too for your contributions. You've emphasized the importance of planning. It all starts with planning. People always say garbage in, garbage out. You may have a system, but if you're planning, your budgeting is not focusing on what you need to be focusing on, you will not achieve what you want. So it's important to translate those health plans into budgets, into work plans, so that you can ensure that the activities that are prioritized are actually and funded at the activities that you want to actually implement. And this was emphasized in the presentation by Henry, Fahad, and Tom as well. And we also need to facilitate this with spending reviews or performance reviews. The team has also emphasized the importance of ensuring that the fiscal decentralization systems actually support effective and equitable spending. And in decentralization, we heard from Henry how sometimes some aspects of health are denied funding because of the belief that health already has enough money. So we need to ensure there are open dialogues, transparency, so that all the stakeholders are aware of the money that is funded, the activities that are funded, so that appropriate activities can be attended to. and coupled with the issue of increasing autonomy, increasing decision space, so that the stakeholders at subnational level can actually prioritize the important activities while looking out for new areas as well. We also had about some of the restrictions that we may have within the public financial management systems, but emphasis was given to the fact that these systems are still beneficial. And Chagoma shared with us how his work was able to show that strong performance management systems strong public financial management systems actually can help improve the health outcomes that we have. He also showed that after the Paris Declaration, the work that was done after that showed better integration of the development assistance for health, and also showed better benefits from that. He highlighted the fact that sometimes this money is not on budget, and so we tend to miss that, and we need to step up efforts to integrate development assistance into the national budgets so that we can be able to maximize the benefits that we can get from it. There was also emphasis on capacity strengthening. Sometimes the structures are there, the tools are there, but the people who are supposed to be utilizing them are not able to do so. And so we need to continuously strengthen their capacity to be able to utilize the system effectively. And lastly, we are always asking finance for more money, but we also need to ensure that we are getting more health out of the money that we have. And so we cannot end without emphasizing the issue of efficiency and ensuring that procurement plans are fit for purpose for health is one of the things that was emphasized by the presenters, but also ensuring continuous capacity strengthening efforts to ensure that those who are budgeting, those who are allocating, those who are spending actually have the expertise, the skills that they require, and that they are ensuring that we are getting value for money out of the hard-earned money that is given sometimes through tax, sometimes contributed by different governments. So ladies and gentlemen, I want to thank you all once again for coming and staying with us. And I also particularly want to thank our presenters. Please join me in thanking our presenters, and feel free to connect with them hereafter to discuss these things some more. Please do give them a hand clap as we end this session. Thank you.
Let's keep the presentation short so that we can also reserve time for questions. So if we can limit our presentation to about 10 minutes, I think that would also be helpful for all of us, because we have quite a number of them and we want to engage the audience as well. So thank you. Welcome.
Okay, next slide. Good morning, everyone. Good morning, everyone. And thank you for this opportunity. Unfortunately, my other authors are not available to join me, but I will try to do justice to this. So just like has been introduced, this is just to give you a little brief on what we did in Liberia. Using innovative tools, simple tools that can actually enhance access and availability to essential drugs in the foremost hospital in Liberia. That is the JFK Hospital. For the presentation, I'll just run through the background next. Run through the background approach, some recommendations from what we did, and lessons learned. Just as a way of background, we understand the importance of access to drugs when it comes to healthcare. We can't speak of service delivery without access to drugs, so we know the critical role accessibility to drug plays. However, despite this important role they play, when it comes to the low and middle income country, we still don't have access, especially in the sub-Saharan area of, in the sub-Saharan African countries. What you realize is that because they don't have access to drugs, in turn, what happens is that there's poor outcome of care. For instance, a woman comes in with PPH, there's no access to normal drugs you use, or the general emergency drugs that you require. And once you don't have access to such drugs, you can imagine what the outcome will look like. And what are the underlying reasons why this remains a problem? One is around financing. I think for the past 3 days, we've been talking a lot about access to financing and how it enhances service delivery. That is a major problem. Another major problem is around availability of data. You don't even understand the drugs that are available. You don't understand how these drugs are utilized for you to make a model to ensure the availability of these drugs. And so based on all of these issues that we also saw in this hospital we worked in Liberia, we thought to look at what are the innovative things we can do within the hospital, something simple, something that can actually enhance availability of drugs in this hospital. Next slide, please. Just as a way of background, JFK is in short, is the only tertiary institution within Liberia. That's where all referrals go to. They see an average of 3 million people yearly. When it comes to maternal, medical, and even surgical care, that is where everybody gets such care from. So when I refer to it as the foremost, that's really where care is being accessed when it comes to Liberia. Despite the position of JFK in Liberia, access to drugs remains a major problem. But I think what is very important or what is very different about JFK is they actually identified the problem and they reached out to us that, please can you come in and help us? We know there is a problem when it comes to accessibility of drugs in our hospital. And so this conversation started. How did we go about this? Next slide. First thing we did was, let's even understand what the problem is. So we did like a scoping to understand what are the structures available, what are the processes available, what are the policies available, what are the forms of infrastructure you have available. After doing all of this assessment, we then went back and said, let's do a proper assessment of what the problem is. So we came up with an assessment tool. Of course, in developing the assessment tool, we used what was already available, did a lot of contextuality around it too, and then the assessment was done. Like you would expect, the assessment was done using a lot of key format interviews, a lot of qualitative question answering, and all of those things. After all of this were done, I was able to collect responses from the different cadre of healthcare workers. We then went back to them. This is what we found. Does this resonate with you? Does this look like what your system looks like? And that was when the validation of the results of all we saw came about. Following the validation, we then sat together. I think for us, what was important was there was co-design of intervention. It wasn't just us coming in and saying, oh, this is what will work. This is what we've done, and we know this is what will work. But there was a co-design process in all of this. We came together and said, these are the problems. What do you think will solve this problem? These are the things we've done in other places that have worked. How can we contextualize these things to your own system, and how can you improve your system? And that's how we provided technical support in implementing some of these interventions. Let's see some of the results we saw. Next slide. The results we saw has been categorized into 3 major areas. One was around governance. What we saw was there were no policies. There were no guidelines when it comes to even the operation of supply chain. They didn't have anything. Everything was just being done by, oh, this is the way I think it should be done. And it was done that way. So there was a lot of variability when it comes to governance in the hospital. Also around logistics, data management, it wasn't existing. When it came to, can we even have an idea of how many of these drugs you're using? How often do you use them? And in any way, are you even making use of any form of data to make decisions? We found that this was generally unavailable. And finally, even around warehousing and inventory. Yes, they had 2 big warehouses, but all the drugs there were just scattered. They were not well arranged. So for you to even identify drugs was war. And we kept asking, so how do you dispense drugs to the various dispensaries? Oh, once the drugs come in, everybody gets their drugs, and then whatever is left, when you need it, you look for it. It was just interesting to see how disorganized the whole system was. And that was how the whole process of improving the system started. Next slide. Bearing in mind those 3 areas, so we worked with them around those 3 areas. First was around governance. Like I said, there were no processes, there were no SOPs, nothing like that existed. And we saw, first thing you do, let's ensure there's a process. Let's ensure the process is uniform. Whatever Officer A is doing is the same what Officer B is doing. So we worked with them to develop various kind of SOPs. In total, 10 key SOPs were developed jointly with the staff of the hospital. Following the development of the two, we then went ahead to ensure there were systems around collecting data. We worked with them using simple tools, like I said. One of the things we used was a Google-based stock management tool to even help them understand this is what is coming in, this is what is going out. This is the expiry date of your drugs and all of those things. Ensure you had normal card, stock card system within the warehouse and things like that. All of these things were put in place. Also within the warehouse, we did as little as arranging the drugs in a format system, even within the warehouse. So those were just like some simple things we did within the system. In addition to this, we did a lot of capacity building, a lot of hand-holding, a lot of mentoring to make sure that all of the systems that were put in place could be sustained even after the project. This just shows a snapshot of some of the things we did around it. And the lower picture there just shows a snapshot of the tool that was utilized and how they were able to improve stock intake and stock outs. Next slide. In a nutshell, what happened? We saw that a mixture of capacity building, hand-holding, and mentoring definitely improved system within JFK Memorial. The use of the Google-based stock management tool was very important in helping them institutionalize a good LMIA system within the hospital. And now what we notice that they're able to collect real-time data on the use of drugs and how those drugs are being dispensed across the various dispensaries within the hospital. Also, what we also realized is that even after the project has ended, about 2 years after, we've seen that there's sustainability within the system. They continue to use this tool. They continue to implement some of these things that we've worked with them to do. And I think what is most important is they're beginning to even teach other people how to replicate the same thing. In conclusion, what did we learn? The buy-in of the management. Like I said earlier on, what was very different about JFK was the management identified that there was a problem. So from the get-go, there was buy-in, and we worked with them to get this done. Implementing high-impact solutions that are inexpensive definitely resulted in a lot of improvements within JFK. And finally, knowledge management, ensuring that they were able to transfer the knowledge of what they were doing to even other institutions, helps to ensure sustainability within JFK. Thank you.
Let's give her a hearty clap. Let me call upon Multilord Ifechi to come. But as he comes to the stage, I think it's good to appreciate how important commodity security is, and I think that has been highlighted. But most importantly, what tools can we put in place, not only to monitor the security, but also to ensure that we have quality products to enable us achieve that. So as that happens, so Multilord is going to talk mostly around surgery. I know it's one of those elements that we hardly talk about, especially on its role, but how it contributes to, yes, quality healthcare. So Multilord, maybe you could just take it up. Thank you. Yeah, you have 10 minutes.
Good afternoon, everyone. My name is Multilord Ifeanyi. I am a research assistant professor at the Global Surgery Policy Unit at of LSE Health, London School of Economics and Political Science. I'm happy to be sharing with you this afternoon our work on the impact of surgery on the economic development of low and middle income countries. But before I continue, I must actually recognize especially the presence of my teacher and my mentor from medical school, Professor Bina Omujekwe. I'm delighted and honored to have you here. Surgery, thank you very much for actually pointing out that, because surgery is something that we've not paid a lot of attention to. Next slide, please. Since 2015, surgery actually, the attention has actually increased. It has become a big thing, a big topic in global health space. And actually that was as a result of the work of the Lancet Commission on Global Surgery, which found that 5 billion people globally do not have access to safe, timely, and affordable care. And interestingly, my senior colleague there, Professor Lison Conte, actually was also part of that work that actually changed the scope or the state of global surgery since then. So I'll just go through the background, the objectives, the study design results, and policy implications, the limitations, and then the conclusion. Now, what do we know already about global surgery, unmet need for surgery? Because it has implications for economics, for the economic well-being of the country. That's why we are here. That's why we are discussing what we are discussing today. We have the paper, again, that Lancet Commission actually showed that between 2015 and 2030, low and middle income countries, we are going to lose as much as 12.3 trillion USD in GDP for failing to provide surgical care. And we also have another paper that actually showed that 28% of all the global disability-adjusted life years lost are due to surgical care. At national level, we actually had a study in Liberia that actually showed that due to unmet need for surgery, the country will be losing as much as 11% of national GDP to productivity losses. So one thing that is common with all these studies is that they look at what happens for failing to do surgery, for not doing surgery. What we've not seen is what we get directly on the GDP, on the economy for doing surgery. And that's why we are doing that's what informed this study. So basically here, what we did was to estimate the direct impact of surgery on economic development of low and middle income countries using panel data spanning 2000 to 2022. What's the basis for this study? Basically, it's hinged on the augmented solo growth theory. This theory basically says that improved labor capacity through education and health will give you improved productivity per capita. So that's direct impact on the economy. So what we just did here was to replace. There's been a lot of work on the link between health and GDP, but what we did here was to actually narrow it down to surgery. And so the outcome variable here, which is for economic development, is GDP per capita. The explanatory variable here is surgical activity, right? Or surgical volumes. But we don't have any database anywhere that gives that actually has the surgical volumes of countries, low-income countries for that matter, over the years. And even if we had that, if you look at GDP, if you look at surgical volumes and then look at GDP per capita, you're going to find a bi-directional relationship. So we're going to have issues with endogeneity. So we tried to be a bit creative in our approach. So what we decided to use was, in place of surgical activities, volumes of sutures imported into the country. And that we got that from the UN. Sorry. Please, yeah, keep going. Yeah, that's it. Thank you. So, but in using volumes of sutures as a proxy or for volumes of surgeries done, that's a very strong, there are strong assumptions here. That also means that we had to take away countries that had local production of sutures. That's one. Two, we also assumed, and this could be debatable, there's also some literature to support this, imported materials do not directly affect the GDP. The key word here is directly. And then from the table, you see a whole lot of other variables that we had to control for in the model. So this was, okay, next slide. So this was our model specification. It was a dynamic model, and we used the system GMM, the generalized methods of moments. Again, for want of time, I won't get into all the details. But basically, what we did here was that where you have problems like creating the classical instruments, where you do your two-stage OLS, you could actually exploit internal instruments in your data set, and that was what we did here. Next slide, please. Okay, so a bit of just overview of the variables. So essentially, we after removing all the countries, then we had to. Okay, all right. So I'll leave this. Let's get to the results proper. Next slide, please. The finding is that for every increase in the volume of sutures imported in kilograms per 1,000 population, there is, it leads to an increase in GDP per capita of 0.01. And these are actual values, these are not percentages. Next slide, please. Next slide. We also had to disaggregate this, separate the low-income countries and the middle-income countries. And what we found was that, next slide. What we found was that for the middle-income countries, the finding remains the same, as around 0.01 increase in GDP per capita. For the low-income countries, we actually even found a stronger relationship of 0.04 increase in GDP per capita for every single increase in the volumes of sutures imported in kilograms per 1,000 population. So we think that, it's not very clear for us, but we think that in middle-income countries, maybe there is actually less room for improvement in health via surgical activities compared to low-income countries. That's one. Two, we also think that in the high middle-income countries, the relationship between sutures and volume and operations, surgical activities might be less because a lot of the surgeries are already becoming laparoscopic. So that's what those are just assumptions. And let me also point out that these are actually ongoing work. These are preliminary studies, and we're still working on this. And the input from this will also even help us in improving this work. Next slide, please. So the key thing here, next slide, please. The key thing here is that for the first time, we are getting to, next slides, yeah, just next slides. For the first time, we are getting something close to causal relationships between surgical activities and economic development. So for surgery that has been abandoned, or was abandoned for a long time, we see economic reasons beyond just health benefits to invest in surgical systems. So this is an advocacy tool for global surgery champions to advocate for investments in surgical care. Thank you very much.
Yeah, I'm loving this, how we are respectful to time, and wish us to continue this way. Thanks again, Dr. Multilord. Thank you. So next is Francis Ilika from HP Plus Abuja. Francis Ilika? We have Francis Ilika? Oh, not here. Okay, good. Yeah, because that was a whole conversation around how we can advance local manufacturing. So I'll call Terifa Alemu. Terifa Alemu. Do we have Terifa Alemu in the room? Okay. Maybe we can skip that just in case comes, then we can go back to it. Pamela Adobe? Good, fantastic. So Pamela, as you prepare, and hopefully we'll get the rest of the team. But by the way, make sure that you note all the questions because you're going to have a panel conversation after this based on all that conversation that you had. So please note those questions. And yeah, so as she prepares, it's also important that we, even as we look at, some of the evidence given around surgery, especially on some of the proxy indicators, for you to even have maybe reflections around what more is happening across the continent, maybe in the areas that you work, how best can we position even to demonstrate the impact of surgery in the economy of our countries. So I'll wish to hand over to you, Pamela, to take it off, 10 minutes. Thank you.
Thank you. Good morning. Okay, I'll be talking on crime in urban areas inhibits provision and access to health services in primary health centers in Nigeria. I have one of the authors here, Professor Obinna Omujekwe, my mentor, and some of my team members, Mimi, Okay, Issa, Prince. They are also part of the study, and also my sister here. Okay, so straight, in Nigeria recently, okay, so there is a kind of, there is rapid urbanization, okay? that most people in rural areas have the zeal and they're so eager to move into the urban area. And this poses a kind of competition, okay, for scarce resources, unemployment, because people need to survive. And this brings a kind of pressure, okay, an increase in crime and insecurity in this urban area. So people strive as much as possible to see how they can survive, and this makes them to be involved in a lot of crime. And this also have a huge effect on health services, both provision of health services and access to health services. So we decided to look into this to find out the type of crime that affects provision and access to health services and the multi-dimensional impact of crime in Nigeria. So this study is actually, we had this study in 2 cities in the Southeast Nigeria, in Onitsha and Aba in Southeast Nigeria. And this is a qualitative study involving 52 in-depth interviews and 8 focus group discussion comprising, so we have some stakeholders from the formal health system, informal health providers, the community leaders, health policy makers, and of course the security personnel, both their policy makers and those that provide security. Our key findings. Okay, so we found out that there are some different types of crime, okay, that are common in these communities that affect provision, and that affects provision of health services and access to health services. So like theft, robbery. In fact, theft is one of the most common crime that we found in these communities. You know, people are so afraid to go to these health facilities, especially at night, because they are afraid that their bags and their phones will be snatched out of them, and they will, you know, this actually affects them. Then, of course, kidnapping. Recently, there have been a high rise of kidnapping, okay, in these 2 cities. Okay, so people are so much afraid, okay, to go out there, especially at night. But this also takes place in the afternoon, in the morning, but is more prevalent at night. Then cases of rape. Okay, so we found out that, especially for female, okay, there was a case that was reported that a lady was actually sick. In fact, 2 females, they were sick and went to visit the health facility around 9 p.m. But unfortunately, one of them was raped, and one of the security people now was able to intercept, okay, and those hoodlums had to run away. Then we have drug abuse, cultism, domestic violence. Then for the health facilities itself, so they also experienced a lot of theft and robbery, okay, and vandalization of health facility equipment and medical supplies, then snatching of phones inside the health facilities. So most of these patients, you know, complained about this, especially in the evening and at night, that some thieves do come in to snatch their phones from them and their bags from them. And most of them now prefer to resort to self-medication than going to health facility when they are sick, especially at night. Then there are also some cases of corruption in procurement processes, and of course, funds. Some of the health workers, you know, do misuse, okay, some of these funds that is meant to provide health services in this facility for their own personal use. Then what are the causes of this crime? So we found out that the unemployment has actually increased. Most people are looking for jobs to do, what to do to earn a living. Then we have peer pressure, then poor parental upbringing, and inflation is actually high, you know, now in Nigeria. Like a lot of things are happening, market, you know, prices do change. Like one can just wake up in the morning, go to the market to buy something or buy petrol less. Then the next day, the price has already skyrocketed. So this affects people a lot. Then the impact of crime. Okay, so the impact of crime in for the health facilities. Now, okay, so one, this leads to increased absenteeism. Okay, so most health workers are afraid to go to the facilities to provide health services, especially at night, because nobody wants to be robbed or killed or something. So they prefer to find a way to avoid these night shifts. And for some facilities now that have staff accommodation, but don't have any security personnel living in these health facilities in order to protect them, they still, prefer to just come from their homes in the morning and avoid night shift. Of course, PSCs are meant to provide 24-hour service, but when this happens, when people feel that their lives are being threatened, okay, and afraid, they seems to avoid to go to work. Then there's also constant fear from these health workers, and motivation is very, very low. So they prefer to just do the much that they can and leave the rest. Then for the community, okay, so we found that financial impact, physical impact, like some people have some wounds and injuries from wound, okay. Then then we also found out the health impact too, like for the rape victims, STIs, unwanted pregnancies. Then for the social impact, people are afraid to engage in social activities. So once it's 7 o'clock in the evening or 6, most people run and go back to their homes. Then people are anxious, afraid to sleep at night, sleep disturbances and all that. Then psychologically, of course, trauma, depression, and all that. So we also found, looked at what can be done, okay, to reduce the impact of crime in provision of health services and access to health services. So on my right hand, we have some strategies already on ground, but this still happen. So what can be done? Okay, so first of all, there is need to provide job opportunities. Please, next slide. To provide job opportunities for the youth and some educational programs, okay, so that people can be fully employed, okay, and earn a living. Strengthening securities around health facilities, okay, by recruitment and training of security personnel, and post them to live in these primary health centers. And for some health centers that have no fence, there is really need, okay, so to fence these health centers, because it's going to help, okay, to provide security to them. Then lastly, there should be a multi-sectoral approach on how to mitigate this impact of crime on urban health. So there is need for the communities, the government, the CSO, the media, to be involved. Okay, so to ensure that that this effect of crime in provision of health services is being reduced, and people should be able to access health services when they need it. Thank you.
Good. Thank you, Pamela. And as you come off stage, I don't know whether we have Thoneng in the room. Thoneng in the room? Okay, so that means we'll have Olaide next to present. But even as you come, I don't know whether, Olaide, you were taught also by Professor Bina, because seems like Professor Bina is well represented in the room. Yeah, but so Olaide is going to talk about the asymmetric effects of oil price on health expenditure and in some selected OPEC countries, which will be a very interesting conversation to have. So as you come on stage, thank you again, Pamela, for highlighting what's probably one of those items we never think about in terms of what this whole relationship between crime and health seeking, and even for the health staff to be there to provide care. And I think that would be an important kind of conversation to have. So also prepare for the questions time when it comes, And that would be it. So hand over to you, and let's take another 10 minutes to listen to you. Thank you.
Thank you. Good morning. My name is Olaide Balogun. I know Professor Bina, but I was supervised by Professor Lawasin from University of Ibadan. So it permits me to stand on a system protocol. So the title of my presentation is Asymmetric Effect of Oil Price on Health Expenditure in Some Selected OPEC Country. This is not my group, I have to inform you, but I was moved to this group because I just arrived this morning. So globally, when you have fluctuation in oil price, it actually affects oil revenue. And this is common among oil exporting countries. Once that's happened, a lot of these members, they depend on oil revenue, and when they are doing their budgets, it affects their budgets. Now, when this shock happened too, economic activities are also affected among this member, and some of them are guilty of allocating stipend of their total budget to some key sectors like health and education. Now, there are 5 countries identified by Salem 2023 that are affected, that these they depend more on oil revenue, and these are United Arab Emirates, Saudi Arabia, Iraq, Nigeria, and Nigeria. Undoubtedly, once this shock affects them, it affects their survival during the year, specifically on their budget. And in the last 5 years or 6 years, the data available has shown that average oil price per barrel dropped from $67, approximately $67 in 2018 to approximately $62 in 2019. And it continued like that for 2020, which was $42 and was as a result of COVID-19 at that period. Then during the recovery stage of pandemic, the price jumped to 63.14 in 2021 and rose again to approximately $88 in 2022. Now, when these prices are going up and down, of course, these major country, 5 countries that I mentioned, they are fond of allocating little to health sector. And to affirm this, the percentage share of government health expenditure from GDP is less than 6% among these countries that we have mentioned. And such share of health expenditure from economic productivity is low, and as such can hamper human capital development of a country, which can reverse growth if care is not taken. And you know, when governments are not doing what they are supposed to do, by allocating a particular percentage recommended during the agreed period of, especially for these African countries, that they should allocate 50% of their total yearly budget on health sector during this Abuja agreement. If they are not doing that, they are going to push the burden to the household, and this is coming through out of pocket. If out of pocket is high, there's going to be what you call catastrophic health expenditure, and when it's more extreme, it's going to push them to poverty if care is not taken. Now, the up and down of this oil price can be decomposed into 2, that is positive and negative, and can be interacted with any choice of your economic variable. But here, I interacted this with health expenditure. So if there's if we have effect of that on if we have the effect of the positive or negative on any of the interacted variable you have used, then we'll say we have a symmetric effect. But if you use it directly and it has effect on whatever you are interacting with, you say you have symmetric relationship. So the following are the question raised for these, and the first one is, does the burden of government expenditure shift to private health expenditure? Is there a relationship between oil price and health expenditure in terms of government and out of pocket? And what is the asymmetric nature of oil price on health expenditure and out of pocket? So I cannot categorically say that people have not, work on this area, but some of them, they actually use oil revenue, and some of them didn't bother to use out of pocket at all. So to buttress my point earlier about what we have with out of pocket and government expenditure among these 5 countries, you could see for Nigeria, we have the contribution of out of pocket average between 2000 and 2022. You have it about 3 times higher compared to government expenditure. And when you go to Iraq, you see it's very close. The difference is not much between out of pocket and government expenditure, but Saudi Arabia is still better among these countries. So this, for the methodology, we rely on the Grossman demand for health medical care. And what that is saying is that when you invest in health, it is expected that the outcome of health in that particular place should improve. So the model, which is health expenditure, you have oil price, inflation, exchange rates, GDP growth rate, and population growth rate. Then the estimation techniques, the first one is the WECT test, ARDL, nonlinear autoregressive distributed lag. That is to answer the 3 questions I mentioned earlier. So, and data was retrieved from WDI and World Bank commodity price. So this is the result for WECT test, and you could see the mean difference for Nigeria and also Iraq. I purposely circled that to show that. The other one is negative, showing that out of pocket is high for Nigeria, and even Iraq, not significant, showing that it is just little different between the mean for GHE and out of pocket. And when you look at the group, you see that what we have is 19.561, and that shows that the difference is not even much, though significant, but we could have seen something like 70% for GHE, and for out of pocket to be lower than that. So for the second question, which is to check whether there's relationship, of course there's relationship, and what we have there is that for the oil price for government health expenditure, we have a negative relationship, while for out of pocket, we are having a positive. But what we have is for long run, why in the short run, this is not significant. So we can say it's in the long run that we could expect this kind of relationship and being significant. Then for the asymmetry, where we decompose the oil price into positive and the negative, this is what we have. There's negative relationship for government expenditure as well as out of pocket. Why in the long run, why in the short run, we still don't have the result to be significant. So conclusion and recommendation, the symmetric and asymmetric relationship between oil price and government expenditure as well as out of pocket in the long run, not in the short run from the result. The implication of this is that irrespective of the type of health expenditure considered, health expenditure on health react to oil price changes in the long run. Also, this study shows that governments of these countries are insensitive to health sector in terms of spending, and the burden of out of pocket, that is OOP, is pushed to household. Then being sensitive to this sector will help to achieve the third goal of SDG, which is good health and well-being. By so doing, human capital will help to increase their economic activity, and the spillover effects will be felt on other economic activity. And also because you know that the SDG are also interconnected, of course, this spillover can be felt on other goals and can also be achieved. Thank you for listening.
So thank you, Laide, and especially the fact that you didn't have to wait for me to raise the, the time is up time. So that is very, very great of you. So I'll wish to welcome all the, the speakers to the stage. So Makinde, Martilord, Pamela, and Olaide, please. Yeah, just go with it. Just come with it to the stage. So we've had a very interesting conversation, and I'll wish you, it doesn't have to be questions to the panelists, but to the speakers. It's largely around what are your quick reflections in terms of the places that you're working and the spaces you're working in, especially around the things that I've talked about. So right from the start, we had Makinde talking about some of the tools in Iberia that they're putting in place to ensure, to monitor commodity supply chain and to ensure that there is commodity security. And then Matilode talked about a very interesting conversation that hardly comes up, especially around the connection between surgery and economic development. I know it will be interesting also, Matilode, for you to just expound more in terms of how, because it's not really widely talked about. In fact, when we're talking about maternal mortality, largely we talk about, delivery and all that, but no one ever talks about the role of surgery. And what is the impact of, let's say, poor surgery on maternal mortality itself? So Pamela talked about crime and provision of healthcare, so that would be an interesting conversation. And finally, Olaide, who talked about the oil price and health expenditure. So I'll give a chance to all of you, for any question, please put your hand up. And that question can be directed to one of the speakers, or if, you have a very, overarching question, it would be great to hear from you. So any question from the audience? I'll probably put on the spot the professor who was taught everyone on the stage. Just in case you have any comment or question. Over to you, Professor Bina.
Thank you very much. I think the Google-based Google-based stock, I found it interesting. But how does that fit into the procurement process? Because this is just for the stock taking. But if procurement is faulty, whatever stock you're doing there, it's not useful. So how does it fit into the procurement process, and how have you tried to make sure the procurement process, is done properly? And then how does also whether you use an essential drug list to develop this Google-based tracking? I think that's what I wanted to raise something. But my question is, it didn't come out clearly, because there's always a debate about, especially now aid is gone. We're told that aid is gone. We need to rely more on domestic resources. So I was looking for a clear-cut message coming out. If we have increase in oil resources, to what extent will that be used to fund health? I don't wonder whether you can answer it from the analysis. Thank you.
Thank you, Professor Bina. Let me quickly run. I'm sure today I'll add more steps on my Fitbit. Thank you.
Thank you. You're earning your buffet lunch. That was a wonderful session, and I came to this session. Part of my bias was around learning about local manufacturing of health commodities, and I wonder, and that you weren't intending to speak on that, but I wonder how that could influence each of your talks, if you think that is a priority along the way to have that capacity built. And the other was around crime. I've never really thought of it, and it was really startling, and it's made me think a lot. And you hear more and more fragmented information and evidence on caring for our carers, really. And I wondered if there is some sort of joined up effort where we think about not only increasing coverage of health workers, but also just keeping them safe in their workplace, and thinking more holistically about how to improve their working conditions.
Good, and interestingly, I was also very keen to listen to local manufacturing, but seems like the people that are supposed to present on it, maybe they knew we were here, that's why they didn't come to tell us about it. So thank you. I hope you're noting the questions. I know some of them are cutting across, but it would be interesting if at all there is one specific one that comes to you. Thank you.
Thank you all for your presentation. So my question is directed to Dr. Matilode. So I know if you had a bit more time during your presentation, you probably have addressed this, but I'm just trying to call your attention to it again. How did you address the potential sort of endogeneity, reverse causality between your explanatory and outcome variables? If you just provide a bit more information on that, thank you.
Okay, good. Yeah, Matilda, I hope you've got that question right. Any other question? Any other question? So let me turn to the team, and so I'll start from you. So the question is largely around, we're talking about aid is gone, and now you're coming up with a different dimension. So it's like, we actually have money. So how are we going to link the two? Over to you. Yeah, you can use this.
I want to call the attention of our professor that about 10 minutes ago, I just got a breaking news that $1 billion has been allocated by Tinubu government to maternal and infant care just this afternoon. So, and I feel because aid is gone, that's why they are doing all of this. And because we now, for Nigeria, we now produce locally. And like one of my sisters here said that the price is going on up every time because of inflation. And you could remember that because they removed subsidy, that's why we've been having an increase in prices over and over again. So I feel if you actually depend on oil, and this oil is bringing more revenue, you don't basically say that this certain percentage you have been allocating over the years is what you constantly base it on. If you have seen outcome in whatever you have allocated to it before, it is expected that an increase in the revenue of oil in that particular environment should spread over as a spillover to different sectors and should, in a way, increase the percentage of that allocation to that sector. And you said from my result, you were unable to pick the result. Now, for the symmetry, there was a negative relationship between the government expenditure and the oil price, which is saying that when there's an increase in oil price, there's reduction. So for me, it then implies that they are not taking conscious of the time when there is boom and when there's crunch. So when there's boom, the other sectors should also feel the impact in terms of allocation. And when there is crunch, there's what you call business cycle. There's a way you adjust to that. And that's my angle of looking at it, sir. Thank you.
Good, thank you. So I'll probably, move over to Pamela. I know one of the questions directed to you is, framed in a very interesting way, that is taking care of the carers. I know in most cases, a lot of conversations have been coming up around taking care of the carers, but from a mental health perspective. And it will be interesting to hear from you, especially on, what more is that can be done, and what other angles are we looking at it, especially from a system perspective. So just responding to her question. Over to you.
Okay, so based on her question, what can be done to improve, based on my topic, that talks about crime, and I hear you mention about infrastructure development, what can be done to ensure that it helps in providing health services, So in our Nigeria health facilities, so there is real need to improve some of these infrastructures. Then when it comes to security, so there is need at least to create a space, for these security personnel when employed, for them to be in these health facilities. If possible, like some of the stakeholders also mentioned that there is need to install CCTV cameras in these health facilities, although this might not really be so visible at the beginning, but maybe if some private partners can actually come together to support this, and people also from the community, it might be workable. So if all these are being in place, it can actually help, to improve securities in these health facilities, and of course, provide access to health services in the communities. Thank you.
Good. Over to you, Matilda. I know, I mean, there was a very technical question asked to you, especially around the methodology, so happy to get your answer. But I think from a personal perspective, it would also be important if you could add a bit around the economic impact of failed, poor surgical practices. How did you have any sort of perspective on that? Is that something that you've had, maybe some kind of experience to share on top of, I mean, some of the perspective that you gave? Over to you.
Are you talking about unmet need now? Failure to provide surgery?
No, like providing poor surgery, poor quality surgery.
Okay,
Yeah.
right. Okay, I mean, thank you very much. I picked up a few things. I'll probably just try to respond to all of them before I come back. I'll come down to you. Even before earlier on, you mentioned what could be the impact of surgery on maternal mortality and all of that. So surgery, like you clearly pointed out, was actually neglected. But it's good that at least to some extent, at least within the academic circle, the global health circle is getting attention. But in terms of what is happening on the ground, I don't think there's been a whole lot of progress, really, even with the development of national surgical plans going on. At least 10 countries in Africa now have it. But one thing is this, it's something that cuts across every field. Because even for medical cases, if you have diabetes, it could get complicated and then you need to do surgery. For maternal and child health, it's a key intervention there. For NCDs, whether it's cancers and all of that, it's a key thing there. And yet we don't pay attention to that. In fact, there's a study actually showed that the morbidity or the burden of morbidity from surgery is actually bigger than the morbidity from AIDS, HIV, TB combined together. And these are things that have actually had the biggest attention. But okay, like I said, the evidence is emerging that we need to pay attention to this. So it's something that affects every other sector of the health system. And in terms of the quality, of course, there's also evidence that the quality of services, the quality of surgery we have in, let's say in Sub-Saharan Africa, for instance, is lower than what you have in the higher income countries. A pregnant woman is several times more likely to die from cesarean section here in Sub-Saharan Africa compared to what you have in US or Europe, and that's a problem. Of course, if you do a surgery and it's poor, then you have complications, then you probably need to use more resources to fix that. That's if you don't end up with death on your hands. So it's a huge problem indeed. And I'll go back to what Professor Conte actually mentioned earlier about local manufacturing. For surgery, that's a very key one, because surgery is one thing that requires the full complement of the whole health system. I mean, the human resource, the infrastructure, you need the theater, you need a full team in the surgery, you need the surgical systems, you need the supply systems, the supply chain, you need the governance, the financing, everything you need for the full health system is what you need for a single case of appendectomy. So if we focus on the manufacturing, for instance, the fact that we were able to even do this study, having 90-something countries in low and middle areas, region, that we did not find evidence of local production, on its own is a problem. I mean, for this study, it was an advantage, but in reality, it's a problem that we have all these many countries not producing sutures. These are key things. So indeed, it's important. It's a wake-up call that we need to strengthen local capacity, because also a lot of studies have looked at the challenges for failure to provide surgery, and sometimes it's something as tiny as sutures. My work during my doctoral days in Tanzania, sometimes you see a hospital with full capacity, full human resource there, like all the equipment there, and then they cancel surgery because there are no sutures and basic things like that. So it's a big problem, and if we can produce locally, it's going to, at least to a very large extent, solve this issue. We'll go to the big elephant in the room, and that's the issue of the methodology. Everybody will agree that the issue of causality and establishing impact is a big thing for econometricians, and it's something we take very seriously. And if you probably, in my concluding remarks, where I said, well, for the first time, I was very careful with my comment. I said, for the first time, we're getting figures, we are coming very close, something closest to causal impact. So meaning that there are still a lot of issues around that. So what we did basically, and like I also highlighted, if you look at surgical volumes or surgical activities and GDP per capita, if you do, we expect that if you do surgeries, you're going to affect GDP per capita. But of course, good GDP per capita also affects the health systems, affects your hospitals, affects what you do. So to reduce that, at least the what we have to deal with, that's why we didn't do surgeries directly versus GDP per capita, even though we don't have the data anyway, but even if we did, it's a problem. So we have to use volumes of sutures imported into a country on the assumptions that the volumes of sutures we imported do not have a direct impact on the GDP, except through improvements in surgical services. It was an attempt at instrumentation, but again, that doesn't go very far. So then we used the GMM, the systems GMM, which is a way to exploit internal instruments. So basically, because we couldn't get an external instrument, and what you want really for you to deal with endogeneity, you want to establish exogenous variability or variation, which is always the problem. So in the absence of a valid, which was what the first thing we tried. For instance, we wanted to look at some data on natural disasters, which is completely exogenous. If we have that data, we're trying to relate it to surgeries to see whether there's any link. That didn't fail, and that's still an ongoing work. We would have wanted something like regression discontinuity. We would have wanted something like synthetic control approaches, right? Even if we had just a number of countries with good data, we could have done just, even if it's just difference. I mean, these are the preferences. So what we had was like the best, and that was the GMM. Basically, what that does is that you use the lagged forms of the variable of interest as against to cut away, try to deal with the endogeneity. And of course, we can continue this conversation after this.
Okay.
Thank you.
Good.
There are times that for endogeneity, you could use internally controlled variable, and that's why GMM is there. The lag variable will do that. Then for the causality you were talking about, you could quickly look into it. Probably you could look at granular causality. There are a lot of measures on that causality you could look at just to show a clear picture of what the direction look like. Is it bidirectional? Is it a one-way thing? So you could also look into that and look at the methodology you can work with so that you can have that future in the work. So I think.
Yeah, so thanks, that's very useful. We also actually did all of that, and including the root mean test and all of that. But of course, we had to cut it off for the purpose of this presentation. So, but thanks, that's it. But we have it in the main work. Yeah, thank you.
Good. So Makinde, over to you.
Thank you so much. Thank you so much, Prof, for the questions. I think I'll start with the essential drugs. Yes, I think when we kickstarted the use of the tool, we started with the essential drug list. That was actually what we used for the pilot. When we saw that there was perfection with the use of essential drug list, we then added additional drugs for its use. And then you're absolutely correct. There's no, you have a stock tool, but you don't have a procurement process, which was actually what we saw in JFK. The procurement process was very, very porous. And that was one of the SOPs we developed. We actually developed an SOP to guide them when it comes to procurement. So what we saw was, after we're able to guide them through ensuring that they had a good process when it came to drug stock, and knowing where the drugs were going to and all of that. The next level was procurement, and to ensure they were even able to procure well. If you know a little about Liberia, you know that they've gone through a lot of really, really hard times over the past couple of years, going from the civil war and then to the effect of Ebola. So really, most of their procurement, like it is majorly fronts or drugs being donated to the hospital. But I think JFK as a hospital has also graduated to the process of even procuring more and more drugs by themselves. So yes, they're already using the procurement SOPs to guide that process. And that would just fit into the last question about local manufacturers. So yes, like I said, Liberia, they don't do much. They don't manufacture anything currently, at least when it comes to drugs. So what they're exploring when it comes to procurement is to look around Africa. One of the things they did at the end of our work with them was they started exploring getting drugs from Ghana and even Nigeria. So they started conversations with local manufacturers within Ghana and within Nigeria to see how they can make drugs available in the hospital. And not just even make drugs available, they were even able to secure some credits facility to ensure continuous availability of drugs within the hospital. So yeah, that was the way we connected it. Thank you.
Good. So thanks again. And I know we are coming to the end of this session. I'll wish to, I've seen one question and we're not going to leave it out. Make it brief and possibly if you're directing to someone in the panel, feel free. Thank you.
Thank you very much, sir. Okay, so it is just like a form of suggestion because the presenter that presented on crime, right? So I felt somehow I was touched hearing that some people were denied the access to the healthcare system because there were sorts of crime in that state, and I thought of suggesting a form of a possible solution to that by adopting the use of technology, right? If the people of Onitsha, right, can adopt the use of digital health support, I think that would not totally shield them away from accessing healthcare. They can as well benefit from, health services while they receive it online. And that can also be possible. You can search for MDoc online and see that they prefer a digital support, which is already in Nigeria, right, working. So you might want to suggest that to the team and see how it can get to the people before the government can actually see what to do to the crime. Thank you very much.
Thank you. I told you, we rarely talk about crime in health systems. So I'm not surprised that you're having a couple of questions. Do you have a few seconds to maybe add to that?
Okay, thank you so much for the suggestion. So we are going to discuss this. In fact, we plan to have another stakeholders engagement. So we are going to propose this to them. Yes, of course, it's already ongoing in Onitsha, but we are looking at those at the grassroots level, like the poor masses and those illiterate that cannot, use this technology, okay, to access health services. So what happened to them? But thank you so much for this suggestion. So we are going to also add this to what we are going to provide to the team. Thank you.
Okay, so good. So we're coming to the end, but I'll wish to give the panelists, each of you, about 15 seconds. So the theme of the conference is resilient and strong African health systems. Just a quick word on what are your thoughts on how, from your perspectives, how can we strengthen our health systems in the African continent? So who do we start with? Just a few sentences in terms of your thoughts, what your reflections have been, either from the work that you've been doing in this, for this panel, but also broadly some of the areas of work that you do. Who wishes to start? And that would be like your parting shot for this. Who wishes to start? Thank you.
Okay, so my suggestion in terms of how do we strengthen our health sector in the African countries that we need to deal with, especially when you look at Nigeria, we need to deal with the issue of brain drain. A lot of our doctors, nurses, they are moving out of Africa in search of greener pasture. And additionally, the lady there suggested that we need to look at local production as well. That when we produce locally, is a sort of having easy access to drugs. And when we have easy access to drugs, we're expecting an improvement in our health outcome, the health sector as well. For instance, I could use myself as an example. When I did the first surgery, it was CS, and it went well. The second one, there was issue of increase in prices. So the branded drug that I was given, the first one, was expensive, so the doctor recommended a generic one. So, and for a whole month, and I can say that I was smelling to myself because you cannot shower until the wound is okay for you. So the generic drug given to me, it was locally made. Maybe it was not perfect. So we also need to, even if we are producing locally, the quality has to be there. So, and that could improve our health sector. Thank you.
Next, 15 seconds.
Okay. Okay. So for me, I will suggest that, now that the U.S. funding has been withdrawn, so what do we do? Okay. So the government should actually try to fund the health system. Okay, and not just funding the health. Okay, so of course we have funds already, some funds already. Okay, to improve these health services. Then, but the key point now is accountability issue. So we need to actually improve on the accountability, of these health facilities, in fact, the whole health system, and reduce corruption. So we need to talk about corruption. We need to talk about how do we strengthen this health system to ensure that the funds already there are being used for what is being budgeted for. So this is going to help. Thank you.
Fantastic. Matilda?
Thank you very much. For me, I think somehow there's like a framework. If we look at just the health systems framework, the building blocks, maybe it's overemphasized, but I think it's a practical tool for every country to look at its own realities. The one thing I actually found out, like across different countries, is how there are lots of difference and heterogeneities. So, but I also think that we were having this conversation with some of my colleagues, and I said, when we had the COVID, it exposed a lot of the weaknesses, but you also see that it affected different countries in different ways. So I think it's good that they all look inwards to see whether it's the manpower that's the key issue, or whether it's, and try to go that way. General, and well, beyond that, on a general note, well, I'm very biased. I'm very passionate about the demand side of healthcare, and I think that is one area that the financing part, the health insurance, we've been talking about resource mobilization, but it goes beyond that. Just mobilization. It's also about like how we are spending, which goes back to what she also said. But if we can empower the demand side, get it right, I already know there's a lot of conversations about, we know what to do about the supply side already. So that's why I'm actually focusing on the demand side, and it's something I'm very passionate about. I think we still have a lot of work to do in that field. Yeah.
Good. Finally, Makinde?
Thank you. I think I'll just describe this in 3 points. One is, I think the African governments need to prioritize healthcare. Just like the like I hope I got that right. Like they said about the study, despite the increase in what's it called? Increase in profits from OPEC and all of that. Despite all of that, the spending on health is still very low. And that's because we don't prioritize healthcare. My people will say because they feel healthcare is not profitable. So it's not something they prioritize. So one, the African government needs to prioritize healthcare. Secondly, yes, we have a lot of framework, we have a lot of policies, but we need to contextualize it. What is doable within Africa? What is very applicable within Africa? That's something we need to prioritize. And lastly will be collaboration, collaboration, collaboration. I think we don't talk to one another enough within Africa. We can learn from one another. There's no need to continue to reinvent the wheel. Something has been done right in another place. Why don't you learn from them and do it and make sure it works for you? I think with those, I'll just pause there. Thank you.
Fantastic. So let's stop the drain. Let's retain. And let's safeguard our health workers once you've retained them. Let's also focus on the demand side and let's collaborate. So thanks again, and please join me in just appreciating our panelists as they walk off the stage. And I don't know whether the cameraman wants to take a photo of us, but we'd like to get photos as well. So please, do you want us to be up there? Okay, good. So thanks again, and I greatly appreciate you as a good audience. Thank you. Yeah, so I guess we can now break for lunch, and thank you again. Thank you. Oh, and I've just been reminded that I didn't say who I am. So, yeah, so I'm Dr. Matiko Riro. I work with the Clinton Health Access Initiative. I lead our health financing work across the region. And yeah, so part of the conveners of AFIA this year. Thank you.